but I'm a researcher too. So I spent almost 80% of my time doing research. I spend some time seeing patients, but they pay me for researching, so that's one of my passions. And my focus is in something that's kind of a new movement in research that I want to talk to you about. That's called patient-centered outcomes research. And it's really interesting because it's just not us as researchers, it's really taking the patient's views and partnering with patients. So we thought INCAP has been really interested in this, and hopefully you will be too, and hopefully this might lead to some neat stuff and questions and projects that we might do in the future. So I've been funded through the American Academy of Neurology, I do some consulting, and this is like a big name, patient-centered outcome research, and you probably hear a lot about doing patient-centered care. It's kind of, at least in the healthcare side of things, we talk about patient-centered care. It's a lot in our minds, but what it means is kind of a big question. So when we think about patient-centered care, when you come to your provider, when we see a patient, we think about giving care that's respectful to individual patients, because patients are more than their disease. Each person is different, and people have different values, so we have to take that into account. Then we have something that's called patient-centered outcomes. That means, what are things that matter to patients? So in medicine, there's a lot of things that, we doctors, do blood work, we look at that, and that's important. But for many patients, how a number on a paper looks like is not as important as how they feel. And that's what we talk about patient-centered outcome. And then patient-centered outcome research is more than that. And there's a big movement in the States. This is not for you to read, it's just so you know that there's a lot of things going on. There's something called PCORI, which is the Patient-Centered Outcome Research Institute. It's based in the United States, it has government funding, and all they do is to fund research that's focused on the patients. And they spent a lot of time defining what it is that they do. And they didn't just, come together in one afternoon and decide it. They had lots of talks, they had meetings like these where patients gave their views with researchers, and they came with all this definition. But basically, the idea is to help people and their caregivers to communicate and make informed healthcare decisions, allowing their voices to be heard in assessing the value of the healthcare options. So really it's about answering questions that are important for patients. And that means, what are patients interested about, trying to understand how different people view different things, trying to see how we can implement things. So sometimes we find things in medical research. How do you communicate that to patients or to providers? Either specialists or your family doctor. So all those things are part of this kind of movement. And in Canada, we have the S4, it's the Strategy for Patient-Centered Research. It's funded by CIHR, so it's now getting more and more, it's becoming very popular. And the important thing about this, and the whole way this is set up, is about engagement. And engagement of you, of the patients, and of the caregivers. So myasthenia, most patients we don't have an issue with, dementia. Those patients, older patients might have issues with memory, but it also means, patients with Alzheimer's is their caregivers, children is their parents. So it's not just the patient, it's the community around the patient. And the whole idea of engagement is not just when we do a research, when we ask you to, fill a form or, that's part of it too. But it's before then. It's when we're thinking about a study. What do patients think? Do you think that the study we're considering, is it important? Maybe you think, that's interesting, but it won't change your lives. So it's bringing the ideas or the concerns of patients to us. It also means when we're designing a study, sometimes we get very ambitious as researchers and we're like, we're going to do all these things. Sometimes patients say, that's too much. I don't want to spend 3 hours with you. I like you very much, but I don't want to go once a month for 3 hours just for a research study. So it involves, getting patients' idea of, how can we do this in a way that works for both of us? And then it's how we disseminate studies. How do we make them known for people? So it's across the board. And that's, I think, what's new. Because like medicine, research used to be really about the researchers and what we thought was important. And there's been a lot of studies about patients groups such as these and how they view research. And this is big in the United States, so you can have this slide, but this is a study done in the States where they had a few representatives from patient groups, people from academia, like myself, and people from the industry, so like pharmaceutical companies, and how they viewed the fact that patients were involved in research. And patients group valued it across the board. So they said they thought their input was important when they were thinking about a research study For us, when we were developing a study, for us when we were recruiting patients, but even also when we're analyzing our data and disseminating our data. And that was a little bit different, so researchers and industry people see that a little bit different. So part of our job and part of what we're trying to learn is how we negotiate these two kind of different points of view. But lots of patients groups actually do a lot in terms of research, just not as individuals, as subjects. So this is a study on genetic groups of patients with genetic diseases. And out of 124 different groups like this, 74% had helped in some way, for instance, by getting money and fundraising money for research. But 50% have helped researchers organize a study, helping researchers like myself or our group. We think this is a good idea. And even 30% have helped researchers analyze the data, which I think is pretty impressive. I wouldn't have thought about my view as a researcher. I would have think, maybe patients, but some patients might be very proficient. They might have other skills that we don't know about, and that might be helpful for us. So this is a thing that's been going on in other patients groups, and that's something I would invite you to consider, thinking about where would you like as the MG Society to be involved, how much or how little. There are some possible nothing is black or white, so people have thought about what could go wrong. Some of the things people have been having issues with other patient groups is, for instance, who owns the data? How about privacy, right? So when we do our study, we have to go through the ethics board, and we are very careful that the data, no one can identify patients, and that'll spread. What happens if the data are hosted in a different place? A lot of patients groups are doing online surveys or stuff. So who owns the data? If someone is really helping us, should they be on a paper with us, for instance, if we publish something? A lot of those little things that sound trivial, but at the end of the day, they might be things we need to think about. But also who comes, how do we get funding and all those things. But on the overall, people think that those things are probably minor. We might need to work around them, but the benefit of having patients working with us is much bigger than the potential, pitfalls. So it's a thing that's growing and growing and growing. And you might see it with your doctors, or I see it a lot. A lot of doctors feel like they're on one way with their views, what we think is the evidence. A lot of patients feel they're on the other way, and they feel there's a disconnect. And that might be true for some ways. What we're trying to do with this is bring this together. So it doesn't mean to do research by patients that's completely unattached to science or the scientific method as we think about it. It's also not to think that we doctors have all the answers and we can just do a study without consulting patients. It's really about bringing these two views together, and that's the patient-centered outcomes. This mixing the science that we bring, our knowledge of the disease as physicians, but with the patient's views in hand, because our goal with all of these is to improve patients' outcomes. So we feel with this kind of new way of looking at things that the best way to go around it is by partnering and working together. So this institute in the United States have lots of standards. They're very, very thorough. And one of the things they're really interested is when we see how patients are doing, to really get the patient's voice. So when you go to see your doctor, if you see us, we'll get you to fill some questionnaires. It depends where you see, maybe they do it or not. But the traditional way, long past years ago, was we just examine the patient and we get an impression. And the patient tells us something, and it's up to the doctor how much we weigh how we see you in the clinic that day and how much we give weight to what the patient is telling us. This whole movement now is to really incorporate the patient's views, and that's why you'll see more and more, not only in our clinics, also in academic centers, that we get you to fill questionnaires. Is because of that, because we're trying to incorporate how patients are feeling. And why would you do this? Because we need to know how you're doing. So things we may ask you about are symptoms. Symptoms are weakness, double vision, but we might also ask you about how you do in your daily life. Because you can have different symptoms, and for some people double vision might be something that's annoying but not really bothersome. For someone can mean that they cannot work. So those differences are really personal. It depends on your age, what you do, where you live, about quality of life. So now we think about this concept of quality of life. That's not only your symptoms. It also means how you perform in your work or with your family. How's your mental health and overall well-being.
Sorry,
Technical problems.
I'm sure you have power. I thought I was giving you a signal. We're okay.
So this is why we need to make a fit of what we're asking of you and what we try to find. And years before, like medicine, all these ways that we assess patients was really doctors. So basically doctors got together in a room and say, oh, we need to see how patients with myasthenia are doing. What should we measure? And we say, oh, let's see, we should see how their arms are doing and their legs are doing. And we all got together and we all agreed and say, okay, this is it, this is what we're going to do. And what we learned is we need to get the patient's views, because really you guys are the best judges of your status. You are with yourself every day. We just see you for 20 minutes or half an hour, whatever it takes. And you know, with myasthenia, especially because it changes so much, it's very hard to get an accurate picture. So we might be wrong if we just, judge you by that small snapshot in time. So this is what we talk about patient-centered assessment, is outcomes are relevant for patients. And that's why we get input for patients. The scales we had, for a lot of them studies to test a new drug, or even in the clinic, we were not really good at asking about those things. So we came to this concept about which symptoms patients were having and how to capture those things. We looked at the scales that we had before. We found that they were lacking in some things, so we decided to develop a new one. And it was a long process. It took us 2 years from when we had the first interview to when we had something we could test in the clinic. And the reason why it took 2 years is because we really want to get it right, or nothing is perfect, but the best we could, and trying to really get input. So we got all the information about those interviews. We created some items that we tested first. We asked some experts, then we asked some patients. Patients gave us some ideas. We modified it, and we went back to patients, and then so we had like 3 rounds of getting input from different people, and then we had like a draft that we figured it's good enough. And we asked some experts. So we did an online interview for experts who see MG. We had like 72 experts around the world, which is pretty neat. And all these are nurses and physicians that have really good experience in MG patients. And for the most part, they were like, they thought, these questions are all worked and we all think it's relevant. And they had just concerns with one. And I thought this was really interesting. We had one question that we were asking patients if you had generalized fatigue of your muscles as the day went by. When we asked the patients, most patients had no issues. So they asked us to change the wording a little bit to make it clear, but most patients said, yes, my muscles get tired throughout the day, like that really represents me. But doctors, the experts, felt that that was not a good question because they felt that fatigue was a very subjective concept. So these are some of the things they told us. For instance, patients cannot determine the difference between empty fatigue and non-empty fatigue. Or patients confuse neuromuscular fatigue with overall tiredness, or is very subjective, and everyone's fatigued, which is really interesting. And these are people, I don't know who said what, but I know a lot of these people. I know they care for patients. So it just tells us the way we're trained. It's a part of the way medicine has worked, where we kind of like objective things. And even the examination is not that objective, like really depends, on the day. Because we were interested in the patients, we said, okay, this is really interesting. We tried to make the wording clear, but we kept it because all our patients told that this was relevant in the small group. So we decided this was an interesting piece of information to see how we view differently, but we went with the patients and we kept the item.
So you're saying that doctors are skeptical of patient input research?
Some of them are, and for some things that doctors consider subjective. But, yeah.
Well, I'll answer the question then.
Mm-hmm.
What I was looking with what Kat was saying is, did you ever think of asking the spouse?
No.
Because the fact that when I get an interview, and I will answer it in the same way that you just said, my wife will come around and say, no, I have noticed that you do this and this, and you get tired more faster. And she, being objective, can see things that I don't appreciate.
That's a good point. I think it might have to do with something we call adaptation. People who get a chronic disease get used to having certain symptoms. They get used to habit. They avoid doing certain things. So sometimes they think, oh no, I'm fine. But someone can tell you, you're fine because you don't go out for a walk, because you don't do this and this and this and this. So it's a good thought for us to see how caregivers, and in practice in our clinic, often it's the wife more than the husband for some reason that tells us a little bit more about the input. But you have a good point, something to
because you can't, as a patient, you can't hear yourself as you transition. For example, slurring, as you fatigue is one example. You can't hear it. Your wife can hear it. She can tell, or your spouse, I should say, because it could be her as well. That's what I think is.
Yeah, that's a good point. Yeah, I think in our clinic, most of the time when patients come with someone, they ask, but it's something to keep in mind if we went online and doing this online, that people could get input from that.
But I'm also interested to know, just before you leave this, because I really think it's pretty important, the doctor considers the information to be, you said, subjective, meaning it's an individual's perception rather than the truth, or?
I think so. I think that's what they mean. I think especially with the fatigue, of the other questions, I'll show you an example. They were generally fine, but with the fatigue, they felt like fatigue is this kind of bag of many things. And in part, it's true. So, fatigue, there's a mental fatigue, there's a physical fatigue. But I would argue it doesn't matter how we call it. If patients find that it's important for them, and if it's affecting, and I'll show you some stuff later because we came back to the fatigue stuff, we should incorporate it, because being subjective or not, and I would argue any symptom is subjective, because I can't feel for a patient when you have pain, when you have fatigue, when you have weakness. I can see you're weak, but I cannot feel how weak you feel. I cannot feel how tired you feel. I cannot feel how you have difficulty swallowing. So the experience of life is subjective. Even my objective examination is subjective. It's how I'm seeing it that day. So unless we were machines, we cannot really be completely objective.
One of the other things that I've noticed is that I will be doing something, and I'll say go shopping with my wife, and as soon as I come into the house, it's almost like I've just been hit with a wall. All of a sudden, I'm extremely exhausted, and then I said I have to go to rest.
We had that in the interviews. When we interviewed patients, we had that coming, and that's why we had this kind of global question about overall fatigue. Maybe we should add another one. When you look back at some things you did, you always think you could have done better. The way we frame it, maybe it could be improved, and that's something for the future. But the reason why we put it is exactly because of what you're saying. We have patients telling us that by the time it was nighttime, they couldn't move, and they would rest, and in the morning they would be fine. Or if they did any kind of physical exertion, they would be wiped out. It was not just one patient, right? So, and it kept coming and coming. So that's why we thought it was interesting. And I never thought that doctors, this was a surprise. We were not asking, we were not trying to trick them into but we were just honestly asking for their opinion. And even though we were going to use the scale mostly what patients told us, but, we wanted to know what researchers thought, because they gave us really good input for other stuff, right? So, you should maybe add this word, or, add this thing. So it was really to try to make the best effort we could. And this I found something interesting. I'll show you some more stuff on this subject as we go.
I was just going to say, probably my doctor is one of those, but that would answer like that. But so I will often bring somebody with me, not necessarily because I need them there, but to help reinforce the points that I'm trying to raise when I get there.
So there's a lot of questions with fatigue, and you see by some of the questions of these doctors, they think, some doctors fear that it's not, we know myasthenia causes fatigue, but then they think maybe part of the fatigue is because, patients have been weak, have not been exercising, maybe they have, lost some conditioning. Or, we give you prednisone, we know prednisone can cause some muscle atrophy, maybe some of that. Truth is, a lot of these things we don't know. I would say in a patient with very active myasthenia, it's probably the myasthenia. It's only in those patients who are not really active where we might think it's something else, and then the treatment would be different, right? Maybe reduce the prednisone rather than increase it. But we don't do a lot of research in this, and I think it's because as physicians, as researchers, we're a little bit scared because we don't really know how well to define it. And as researchers, we kind of like to have things neat in a box, and sometimes, things don't fit a nice box. It's just human nature. It's just that we try our best. So I think my view is that we need to think about this and incorporate it more. And maybe we'll see, in some patients it's the myasthenia, in some patients other things. But at the end of the day, if patients are concerned that this is affecting their lives, we should do something about it, or try, and it will depend on each patient. So let me show you. So we kept the item, as I told you, because we went with the patient's opinions, and then we tried it. So if your patients are in clinic, you'll have it. It's a 22 item questionnaire. It seems very long at the first, and I think patients who just have it for the first time take a little bit longer, but patients who come back, now they know about it, they're very, very fast. And it's long because we're asking about all these different symptoms of myasthenia. We know that myasthenia is quite heterogeneous, so some patients don't have any symptoms in the eyes, some only have symptoms in the eyes. Some might just have problems chewing but not swallowing, sometimes, with pronouncing words but not the voice. So there's a lot of combinations, and we were trying to capture as much to try to cover as much as the breadth of the disease. And it's perfect, of course not, nothing is perfect, but we're trying to be as comprehensive as possible. And we have some examination items that we can use or not. The most important part is what the patients answer. And this is more or less how it looks like. So, we have, for double vision, we ask, does it change throughout the day, or with reading or activities that use your eyes, but we also ask how bad it is, right? Same with the drooping of the eyelids. So we try to ask about this fatigue and how the muscles tire with activity, but also how bad they get. So we think that both are important. And we ask for the past 2 weeks, because we know that myasthenia changes. So we can ask about just yesterday. We don't have very good memory, so anything more than 2 weeks to 4 weeks, our memories are pretty bad, so that's why it's 2 weeks. Some patients ask them, why 2 weeks? And that's the reason why. It's the human brain, we're limited in that way, so it's very hard to be accurate if we ask you to how you were 6 months ago, for instance. And we tested in 200 patients coming to our clinic. So we started with a few patients, very in-depth, and then we went broad to a big number of patients. And we did really well. So we looked at how many items the patients cannot fill. It means, if you cannot understand the question, you leave it blank, or sometimes it doesn't apply to you, and that's fine. But it was very few, so that was good. But I wanted to test that question I told you about, that question that the experts had issues. So that question, only 2% of patients could answer. That means most of the patients understood it. For most of the patients, it made sense. But also, it was the question it was the symptom that was present in the majority of patients. So is the one item that most patients said they had some level of. Only 30% of patients, around 35%, said, no, I don't have any generalized fatigability. That means 65% did have. And that was the item that had the most impact on patients, if you see it that way. So then I was thinking about, what the experts said. Oh, patients cannot differentiate it. Some people the myasthenia is well, but they're still fatigued. So we look at patients who are on remission, or what we call minimal manifestation. So those are patients who have no symptoms, basically. And they didn't have fatigue. They scored 0. Patients who had symptoms had higher fatigue. People with pure ocular disease, almost their median score was 0 too. So we thought, patients can tell. Patients can differentiate it. It does seem to be related to the myasthenia, and in fact, it's important for them. So we were very happy that we kept the item, because it was important for patients. And it correlated with other stuff. So we thought it was interesting how getting that view went. And this is another cool thing that we had. So my theory going this is that, doing just a normal examination was not good enough. So I compared in this slide in some of our patients what would happen if we just use, when we ask you to hold your arms. When we ask you to hold your arms for about 2 or 3 minutes, if you come to our clinic, we make you do that. And what would happen if we ask about your symptoms, what the difference are. So for the arms, for instance, in this cohort, and these are patients with active disease, so patients who are having symptoms. When we ask them just to hold their arms and test their strength, 80% had normal strength. 80%. That's almost everyone. When we asked them to hold their arms in front and just see if they got tired, about 60% were normal. So already 20% of patients, passed from normal to having, abnormal exam. But when we asked about their symptoms based on our questions that are, structured and all that, 40-something% only had normal. So between this history and just the normal examination, there was a 40% gap. We would have missed out the symptoms in 40% of the patients if we hadn't included the symptoms. And we found very similar things for the legs. So this is for the arms. So the pale blue is the normal examination. This is the making you tired, and this is asking. And we saw similar things for the legs, similar things for the neck, similar things for the eyes, for the double vision, for the drooping of the eyelids, we used to ask patients to drink a glass of water or see how they see their speech during the clinic as a marker of how speech went. All the time, we found a big gap between the history and the findings. So that reinforced our view that really getting this patient-reported view was really, really important, because we thought we were going to get a better picture. I'm saying, I know it's not perfect, but we're going to get a better picture of how things were. And we compared with other scales, and we found, what we wanted to see. Patients in remission should score near 0, and they did. And as we classified them, ocular myasthenia, mild generalized, or moderate generalized, or severe, the score increased. So, we want scores to go that make sense, and they did. But then what we wanted to see is if it could detect change. So, when we do a study, we try a new medication, we have to find a way to see if patients are doing better or not. Or if you come to our clinic, we try to have a way beyond, just yes or no of how patients are doing. So we wanted to capture that. And a lot of the things we do in studies is, we just use numbers and we look at what something is called statistical significant change. It just means that we plug stuff in a computer, we do a test for statistics, and we see if it's significant. But numbers don't necessarily go with people. So sometimes a lot of studies have shown that treatment is better than another by a number, but sometimes that number is not important for patients. So we wanted to check that we could, demonstrate change, but most importantly, that when patients felt better, our scale changed consistently, and we were trying to also find what was the smallest change that patients found meaningful. Therefore, what's the smallest change in our scale when you come and we see you that will say, yes, this, we have a good idea that you're indeed better or worse, or if you do a study that patients are doing better or worse.
Okay, can I ask a question?
Yes, of course.
When you're doing that study, what could be also relative is, for example, if you did it with me or any other person, if I just came out of my IVIG treatment, and within that week, I would probably perform better.
Yep.
And if you saw me in the 7th week,
Yep.
just prior to, I would perform extremely poorly.
Yes. Well, we did that. So what we did, we tested patients who were receiving IVIG and prednisone. We saw them before and after treatment, 3 weeks. So we were not trying to prove that the drugs work. We know they work. We were trying to see if our scale could pick that change, regardless of the direction. So not only patients getting better, but also patients who felt worse, or patients who were not changed or who did not receive treatment. And we could. So our scale was good at detecting change. I'm not going to bother you with the numbers, but this is the most important. Where patients felt worse, the score in the scale worsened. When patients were in change, in general, it didn't change much. And when patients felt better, it improved by a lot. So that makes sense. It means that when we look at a number, it goes towards what patients are telling us. The next thing we were trying to figure, this is something we're working on right now, is, we have a sense of how much change is meaningful. So we think about more than 5 points is significant. But now what I'm interested in is, when should we stop? So when is a patient good enough? And I know it's an individual question, but is there a number or something that, for the majority of patients is a reasonable state? And we call that patient acceptable symptoms. So is there a level? It may not be, but we're trying to find, is there, a magic number that we can use to get an idea of patients, we should stop and not try to be too aggressive with treatment and then give you all the side effects. So something that we can use in studies, something we can do for policy or for, Health Canada and things like that. So we're trying to find that. It's called the Patient Acceptable Symptom Score. And again, it comes from patients. So what we did here is, because we didn't think about this before, I just thought about it after we collected, of course. But what we use is, one of the questions we asked patients is how they felt, how they would rate their health, from 0 being the worst health you can think of to 100 being perfect health. So we decided, and this could be right or wrong, but we thought 90% was probably good enough. So a lot of people who say that their health is 90% or better, in general, are doing really well. So we look at what was the average score that people who had 90%